I'd like to welcome Professor Partha Kar. Partha is National Specialty Advisor in Diabetes with NHS England. He's co-lead of the Diabetes Girls, so getting it right first time with the NHS improvement. He works as a consultant at Portsmouth Hospital since 2008. He has pioneered many initiatives to improve the care for patients with diabetes. The latest about the Libre, both in patients, in pregnant patients, but generally in patients with type 1 diabetes. He is very much, I think, fighting for equality in care, and I think equality both for patients as well as colleagues. So I think he's a great advocate for fairness. And he's going to talk to us about diabetes and COVID and what have we learned during the pandemic. Partha will start his talk, and then he has kindly agreed to stay for questions and answers after. So thank you very much.
Thank you, Steph. So before I start off my talk, I dialed in about 20 minutes ago, and fantastic talk, as ever, from Adrian. And you sort of teed me in nicely by talking about the equality side of things. So a couple of pointers, because the questions that were coming in were fab, and I think these are the things that we do need to discuss, because it does tie in also with COVID-19 and diabetes. People always talk about diet, and I work with the national team quite closely with the people who look at diets, etc. One thing I would say that people always talk about what's the best diet. The best diet, as Adrian mentioned, is also not just the one which evidence will say X or Y, but it's also which is sustainable. But most importantly, I think if you look at national data now coming through, it's what you can afford. And I think it's a very important point that we all as clinicians should bear in mind, and I've said this to many, many forums. It is quite okay for us to sit with our own privilege and say what people should and shouldn't eat in our clinics. But I work in Portsmouth. I cover an area of huge degree of variation as regards ability to live, so to speak. I do have the people from Fareham who can afford a lot of changes that I can suggest. I also have people living in Gosport for whom the only food available is via the food banks. And when you are, at the end of the day, looking for your tin, can of beans, it's difficult then to talk about glycemic index or how much carbs you should and shouldn't take. So the important message which I will leave about diets, for everyone happy to take questions at the end, is not about what diet we can recommend in the 10 minutes we can have. The more important thing is what we can do to make it sustainable for that individual. And that's where deprivation comes in. And everything in this country, every single poor outcome is related to deprivation. So we just need to be careful that we don't just roll into things which makes the good a bit better. So that's my starting point. So I'm going to talk about COVID-19 and diabetes. I'm not going to bore you too much with details about COVID. Let's jump to a few slides, but a little bit about my background in the past and people I've spoken for. I'm not going to bore you with too much of COVID. You know enough about it. You read about it, and lots of, depends on which conspiracy theory hat you want to put on. It was first identified in Wuhan. We know what it's called, and it's a group of disease process. We've had similar-ish, but it causes the disease COVID-19, coronavirus disease. 2019 came out, so that was the starting point. And these were some of the initial data that started coming out. You can look at those, data sets which came out early 2020, rest of China. And there were signs at that point of time which we knew that was related to age. We knew age was going to be a big, big issue this was before it had landed in UK. And I'm sure people in the audience remember January and February 2020 when lots of us were keeping an eye with it. Can't possibly happen here, won't happen here, not coming, etc. Then these data sets came out next, which came out in end of January, February, and it talked about the other background conditions which were prevalent in the people as we went forwards. People then started having theories as to why people with diabetes mellitus, and some theories at that point of time, they said it were linked with hyperglycemia. We all know the importance of trying to have good glucose control when you have infections and reduce it. And we talked about age and obesity being possible main drivers, but not much data was available on types of diabetes. All people knew that diabetes possibly was going to be a risk factor. Then Kate came along in March, and these are some of the responses that were launched at that point of time. We decided to prioritize services, and the idea was to shut down most diabetes face-to-face services, apart from two. Foot services, especially multidisciplinary foot services, were kept running. Pregnancy, obviously, for good enough reasons. and we prioritize inpatient diabetes services, lots and lots of virtual support, which has been a big blessing in one way, because lots of services have moved towards virtual support. And there was some guidance for acute trust and community trust. But I think bear in mind that lots of people were feeling their way as to what to do. And what we also had was this from London areas. And a lot of, we were really grateful to hospitals like Barts and Guy's and Royal London, Royal Free, who were fantastic at giving us, because that was one of the first areas hit. And these were some of the insights that started coming forward. We had a nice little national group, lots of people contributing. And these were some of the findings picked up, that atypical ketosis was being seen in type 2 diabetes. So a lot of type 2 diabetes was coming in with ketoacidosis. And that's been borne out in data sets we have done more recently, which has just been published in the Lancet DNE, which shows that in type 1, diabetic ketoacidosis rates actually went down during the pandemic. And there are many reasons for it. But in type 2 diabetes, there was a decent spike seen, which I'll talk about in a bit later as to possible reasons for it. People talked about fluid replacement being needed, high doses of insulin, and we saw that ourselves in Portsmouth when we had people on ITU, huge doses, nearly 20 units of insulin per hour needed. So people were being discharged then on high doses of insulin, but then it sort of also peeled off quite quickly. Nursing prone, that caused problems, people being discharged, as I said, on insulin, and then needed a lot of community support, which wasn't necessarily there because nurses were pulled into acute trusts. And so it was not easy times for a lot of clinicians out there. An inpatient diabetes group was formed, led by Professor Jerry Raymond. These guidances were created when they came in, and because of the obvious spike that we saw in type 2 diabetes presenting first up, these were some of the guidelines issued nationally from this group, which was available on Diabetes UK websites. And along with this admission one, subsequently they produced guidelines as to do when they were in there, what to do when they were on ICU, what to do post-discharge. Some really good pieces of work as led by Professor Jerry Raymond and colleagues, which were really helpful, I thought, for a lot of trusts around the country. But these were sort of frantic times, as you remember, in those times. So you can note the point made about stopping SGLT2 inhibitors and metformin simply because of the risk of dehydration and how they would sort of cope at that point of time. This was the first data set that came out. This was from Ben Goldacre's group called the Open Safely Collaborative Factors. And if you can see, even though they look a bit like TIE fighters from Star Wars or flying around the place, if you take a moment and have a look, you can see what is happening there. There was the issue that clearly age was a massive factor in worse outcomes. You can see the lower age groups being more, for want of a better word, protected in inverted commas, but certainly age being a huge factor. And then you can see the obesity risk, you can see the smoking status, ethnicity, and the deprivation, which clearly opened up a lot of debate, deprivation linked with obesity, etc. And then you had diabetes in there, nicely tucked away, which said that if you had diabetes, you certainly had a higher risk. But then they had their control, which had a very binary cutoff of 58 or 7.5%. And it said if it was below 7.5%, the risk was lower than if it was higher. So that was labeled as poorly controlled. And then there were other issues which subsequently led to how the vaccination program prioritizations were done. So if you look at hematological malignancy, that answers the question as to why that group was chosen as one of the top ones to be having had the vaccine. So some really good data which came out from Ben Goldacre, which further prompted the NHS England team to work with the diabetes audit team and the NHS Digital to do data sets all across the country, which produced this at this point of time, which showed all the in-hospital deaths between March and May, subsequently also extended forward, which didn't change the data set. But as you can see, age, once again, huge differentiation as you go along. Look at the hazard risk as you're hitting the 80s, nearly 9 times more. And then you can look at the deprivation index. The more deprived you were, the worse your outcomes were, the ethnicity side of things. And then the interesting thing was the diabetes one, because we split it into type 1 and type 2. Now, type 1 obviously had lower numbers, but the risks were higher at that point in time and still continues to be, which again was not a huge surprise if you go to the literature, because if you look at literature, type 1 diabetes has carried higher risk with things like pneumonia, etc. in the past. But what it did do was split the types of diabetes, showed the importance of making sure all types of diabetes had the relevant protection, and lots of debates in those times, as you might remember, about shielding, vaccinations, etc., going forwards. This was the other data set which was done with it. And as you can see, type 1 diabetes clearly had a higher spike in mortality. But as you can see, the risks were non-existent below the age of, well, nearly non-existent below the age of 50. And of course, that was important, and which I'll show in the next slide, about the messages that we had to give out to the community. This was the separate piece of work, which basically had a simple question. Had the pandemic caused a spike in death for those who had diabetes? This, you can see, is data sets from 2017, which tracked people with type 1 and type 2 diabetes and their deaths over the course of time, the seasonal variation there. But you don't need to be any form of scientist to see what happened in April 2020 onwards. A huge spike of deaths. So lots of people died before their time, in short. So the COVID has been very bad for a lot of people, diabetes community. Similarly, a lot of people affected, huge spike in death rates compared to what would have been normal. So some salient points which we picked up: people living with diabetes facing a significantly higher risk of dying with COVID-19, type 1 diabetes having a higher risk than type 2 diabetes, strongest risk factor, age, and type 1 diabetes, on average, the age was around about 72, while type 2 diabetes was 78. And I make a point here of type 1 diabetes being 72 years, which tend to surprise a lot of people. But people forget that in this country, due to better care, people getting better diagnosis, people with type 1 diabetes live longer. It's no longer a disease or a pathology just of the young. Nearly 50% of type 1 diabetes in this country are above the age of 50 years. So that was that. But as you can imagine, lots of parents were very, very worried. But so the reassurance that we managed to give them, the absolute risk of death was very low under the age of 40, with no recorded death with type 1 diabetes below the age of 20. So that was acted as a reassurance to a lot of children out there at that point of time. Higher blood glucose levels and obesity linked to higher risk, which was obvious. Too tight control or low BMI was also associated with increased risk. Now, that obviously was related to what we didn't know from the data as to whether the lower BMI was reflective of people with other background cancers, etc. But there's good evidence from ITU about what they call the sweet spot as far as BMI goes. Too low BMI going into ITU is not good or conducive to survival as well. Overall death rate for people with diabetes doubled during the early stage of the pandemic. So as I said, a huge shift, and ethnicity was a big factor. And then the added bit that if you have type 1 or type 2 diabetes, pre-existing kidney disease, heart failure, and previous stroke were all at higher risk. If you want to look at one paper which goes through some evidence, not evidence-based, I would probably say more about the possible pathophysiology as to why people with diabetes suffer worse. You might want to look at this one, which came out of the Lancet from Stefano Del Prato and his group. Fantastic paper, really good talks about the pathophysiology, the possibilities. So that's one sort of CPD to take away, if you so choose to say. But it is a really good piece of paper. Some excerpts from that piece of paper, which I will share. It looks at all the databases according to pre-existing diabetes, all the data sets that have been produced. As you can see, the prevalence of diabetes, the outcomes of them, different countries, China, Italy, and then obviously for subsequently what we did in the UK. But it pretty much had a consistent risk factor that if you had diabetes, you had a higher risk factor. So very interesting sort of amalgamation of all the studies. It's worthwhile looking at. Again, this one looked at the HbA1c cutoffs for people with diabetes. Again, a conglomeration of all the studies done. In plain simple terms, the higher A1c, the worse your outcomes. And I think you can see that in the data set that's come out of the Lancet Diabetes and Endocrinology done by the NHS England diabetes team. If your HbA1c is closer to 9%, 10%, it just keeps on going up the hazard risks, so to speak. Some potential mechanisms which are discussed in the paper. Again, I'm not going to spend too much time on it, but again, you can have a look. But I'm going to mention some of this here, which sort of summarizes the paper. They talked about the possibility of the SARS-CoV-2 causing beta cell damage and thereby the spike in DKA rates, associated cytokine storm, admission hyperglycemia, which would explain some of the things that we have seen about people with type 2 diabetes or not known type 2 diabetes, maybe in a pre-diabetes state, which we don't know, presenting in fulminant DKA. There's a lot of discussion at the moment going on about a possible spike in type 1 diabetes prevalence as well, which is under investigation at the present moment of time. But lots of theories as to why they might all add into the place. And then you add in the other factors of renal disease, hypertension, older age, the outcomes were poor. So that was pretty much the theory of where things were progressing. So some of the response to data was the national team worked with some of the companies concerned. A big thank you to companies like Novo Nordisk, Insulet, etc., with whom we set up a national advice helpline to take some of the load off the specialist centers, people phoning in with worries about high blood sugars, low blood sugars, and we tried to do that and obviously Diabetes UK was a fantastic partner. One advantage of this was also, so to speak, was a rollout of education platforms in type 1 and type 2 diabetes. And we suddenly managed to shift this whole dial whereby we had struggled to move away from the traditional means of providing education, which had to be face-to-face according to some centers. Right now, every single person with type 1 diabetes has access to an online self-management or education platform, irrespective of the age or where they are. It's free, it's available, it's had a really good pickup, and the type 2 diabetes platform is being rolled out too as we speak. There was a group which came together of healthcare professionals called Diabetes 101, ran lots and lots of sessions on different platforms of social media, education, support, talking about the importance of good control, mental health support, talking about when vaccines came out, the relevance of it, different languages. So tried to help in the community as much as people could do during those difficult times. Further on, we have had plenty of discussion with the Chief Medical Officer's team regarding shielding, when it came off, which group needed to be shielded, why not, why in, why out. Dexamethasone came into being because of the trials being done, a recovery trial, which was very, very strong and positive. And as you would imagine, the impact of dexamethasone, which wasn't insignificant, as far as I recall, 6 milligram prednisolone is about 40 milligrams, and it was a huge, huge load of steroids in the system, thereby causing spikes in diabetes, poor control. So we produced another guideline around it, which is also on the same website that I mentioned previously. Again, very helpful to teams. The idea was if somebody had come into ITU and they were given dexamethasone as per the protocol, and they had diabetes and the blood sugars were spiking, what would be the treatment regime to help ITU colleagues? So that was also put out there. I mentioned briefly about SGLT2 inhibitors in type 1 diabetes being held off, being due to risk. I'd just like to mention at this point of time, since then we have done in the overarching, in all the admissions, we've looked at all admissions and all medications, and there is no medication which makes your outcome worse. So pre-start of any medications hasn't really made any difference to good or bad. I know one arm of the recovery trial is probably looking at one of the SGLT2 inhibitors at the present moment to see the impact of that, but we haven't seen any worse outcomes. And that is important to mention. So the message being, don't stop any medications preemptively. In fact, it's important to re-emphasize the importance of good control. The vaccine obviously was very important, and a lot of debate, a lot of discussion, but we managed to get everybody with diabetes into the sort of the cohort. So everybody with diabetes, as per age limited restrictions of the vaccine allowed, was able to have access to the vaccine. We have had really good pickup in the diabetes community and done a lot of work to try and improve that. And as it is, we had to do a lot of work in the ethnic minority population to try and encourage uptake. Similar picture as with anything else in the country. I also wanted to mention the risk calculator. Some of you may or may not be aware of the Q-COVID tool, which was developed by Julia Hipsley-Cox from Oxford and our team, which was an extremely good and useful tool. The idea was to try and input into that tool, just like you do for cholesterol and stuff, and see your risks. I'm not quite sure how much of it is in use right now, but certainly in academic circles, that was one of the things that came out, a piece of work using all the database we have had. So that was a bit of the work that went on. So finally, what we have tried to do is reassure all with diabetes as much as we can do, continue to look at data to pick any obvious triggers. We've got data right now on, as I said, diabetic ketoacidosis data has come out, which hasn't shown an overall increase. Type 1 certainly gone down, which could be a combination of factors. Could be the fact that we have had an explosion of self-management devices like Freestyle Libre, CGM, etc. We've had a really good support from lots of centers. Type 2 has gone up. I mentioned as to some of the reasons for it. And amputation rates have gone down all across the board, major, minor. Does that mean it's a bit like a tsunami where the sea goes back and it comes back again? We don't know. Could be that. Could be we're keeping an eye on it. Could also be the fact that a lot of people were not mobilizing, being at home. Similarly, with type 1, a lot of people didn't go to universities, less parties, less socialization. They all have a bearing. But amputation is one we're a bit worried about, I must say, because we know the care process have dropped off, understandable reasons in primary care. So that's something, a focus that we have, trying to sort of pick that up as we go along. I mentioned about medications we looked at, no obvious medication causing any harm. And a lot of effort right now is focused on the recovery process, which is how we can try and get primary care to pick up on the care process, which, some of you may have heard me say that primary care are under the cosh big time from all quarters. So I've got a lot of time and empathy towards colleagues who are doing the work they do. It's not easy. And all I've said to everybody is do the best you can. There is no sort of stick from us that you have to do X, Y, and Z. And I do expect it will take time for the recovery process to catch up. And that's the reality we face as we ask primary care to do everything at the present moment. Some other bits about what Primary Care Diabetes Society have done, which is quite good. I thought I'd mention that they talk about outpatient appointment prioritization for specialist diabetes appointments. I think it's quite useful. Here is the tool you might want to look at. It talks about which patients to have diabetes, remote diabetes review, which patients to have virtual, when to defer an appointment. Sounds quite reasonable, sensible, and lots of people can use it as a guide as we go along. This is something that we did across the 4 nations, remodeling diabetes services, emerging innovation. Again, you can have a look if you so choose. It talks about the same things that most of you would know. How do you use as much digital tools as you can do to try and help in these present times? So a bit of lessons. There's been some acceleration of much needed work, I must say, in the digital sphere. Care with access, that's been a big, big thing. How do we do it? But I've talked at the very beginning about socioeconomic determinants, cultural sensitivity, and widening the gap. And I genuinely believe we need to be more careful about how we are putting it across. And I'll mention this very clearly. Deprivation is not equal to ethnicity. I've been to meetings where people have said to me, and they've had companies come to me and said that they're really tackling the deprivation thing, to which I've asked, how are you doing it? And the answer has been, we have created some modules in Gujarati, which is fantastic. But for the young child in Stoke, the Gujarati model is not going to do anything. Then we have missed the basic picture. I think there is intersectionality between deprivation and ethnicity, but there's a lot of work to be done. Deprivation is a massive, massive issue in this country. Some of it is beyond us as the NHS, but some of it is also within our grasp. And I mentioned this about how technology helps. And I mentioned also about the fact that there is very clear data that if you're a Black child, your chances of getting a technology in type 1 diabetes is exactly half of that of a white child. That is not acceptable in 2021. That is our fault as the NHS. That is our fault for not finding out why the Black parents cannot come with their child to the clinic, and what necessary adjustments are we doing to make sure that doesn't happen. And I think COVID has shown us that. COVID-19 and diabetes has shown a very, very simple thing. Diabetes causes you to have a higher risk of worse outcomes with COVID, yes, but you have even worse outcomes if you're poor. And if you tap that in with your ethnic minority background, it gets even worse. And some of it is long-standing. This is not new. And I think that's probably one of the biggest lessons we should take away from COVID-19, and what we can do as clinicians to close those gaps. And I'll finish with that. And that's my appeal to everybody who listens to these talks, that in your clinical area, just think of what you're doing for somebody, irrespective of their ethnic minority or their deprivation. And they're not interchangeable. And that's where you will find the ones who need our help the most. Giving technology to people who are already doing very well, the gains are there, but it's minor, it's marginal. Then there's no difference to us and an insurance system which only gives the cool kits and the cool stuff to the ones who can afford. I'll leave it there. Thank you very much. I'll take any questions.